We're going to go ahead and get started with our next session. Welcome back. The next session is entitled Beyond the Little Green Giant, Next Generation Fluorescence and Moving Beyond ICG. We have 3 speakers, Tim Lautz, Marcus Malik, and Dominique Simons. And this session will be moderated by Dr. Simone Mabib and Dr. Shahab Shafi. At the conclusion, there will be a 15-minute question and answer session. We'll just move from speaker to speaker, and then so save your questions for the end. Also, as a reminder for those who are joining virtually, there is an option for entering your questions or comments in the chat, and we have 2 chat moderators, Dr. Laura Boomer and Dana Schwartz, so thank you for doing that through the day. All right, we'll get started.
Morning, everyone. It's a pleasure to be here with you today. So we're looking forward to this very exciting session on Beyond the Little Green Giant, Next Generation Fluorescence, Moving Beyond ICG. I have the pleasure to moderate this session with Dr. Shahab here. And I think that without further ado, we'll have many insights, and we look forward to further steps and research that we could maybe gather together. So we look forward to hearing the presenters. Without further ado, we'll introduce Dr. Tim Lautz, who is an associate professor of surgery at Northwestern Medicine and director of surgical oncology at Lurie Children's Hospital.
Thank you, everyone, for being here today. We're going to talk today about next generation fluorescence. And so really moving beyond ICG. And I'm going to start this off today by talking about the folate receptor and some of these other novel agents. Go ahead. So I do have some disclosures to make. I have received research support from On Target Laboratories, who makes perfluocyanine. I've also received research support from Astellas Pharmaceuticals, who makes one of the novel ureter imaging agents. And I am going to be discussing off-label uses of these medicines, including off-label uses of ICG. Go to the next slide. So fluorescence-guided surgery in the field of pediatric oncology has really, go back, please, has really exploded in recent years. And the role of fluorescence guidance has expanded to now include things like margin delineation for primary tumor resection, identification of metastases during pulmonary metastasectomy. It also works really well for sentinel node detection. And it can also be used for identifying adjacent structures for protection during surgery. And we've summarized some of those applications in a fairly recent publication. Let's see if this is working yet. Oh, yep. Okay, it's working now. So sentinel lymph node biopsy is an example where the current technology with ICG works great. And so with this approach, you inject ICG in a peritumoral location, usually subdermal. You can actually see transcutaneously the lymphatic channels lighting up. You can basically do a percutaneous lymphoscintigraphy and identify the sentinel node. And then after cutting down, you can really hone in on the areas with the greatest fluorescence, just like you would with the gamma probe. And so this is an example where ICG works great. Liver tumors is another example where current technology with ICG works great. And so you can use it for primary tumor resection. This is an example on the left where in an extended hepatectomy, ICG can be used to understand a close margin. It can also be used for pulmonary metastasectomy. You can see an image in the middle of contrast mode where the hepatoblastoma met is lighting up with the fluorescent agent, and then the corresponding picture in the white light mode. So, when ICG is used to detect non-hepatic tumors, whether primary or metastatic, it relies on something called the enhanced permeability and retention effect. So this EPR effect is the concept by which molecules of certain sizes tend to accumulate in tumor tissue much more than they do in normal tissue, due to differences in endothelial permeability, angiogenesis-driven blood supply, and impaired lymphatic drainage. So basically, the tumors have leaky capillaries that let ICG in, and then impaired lymphatic drainage, so it holds on to ICG. And so this allows you to give big doses of ICG that'll clear out of normal tissue and stay retained within the tumors. So this approach can be really helpful. It can be used both for primary tumor resection and for pulmonary metastasectomy, but there are both false positives and false negatives. And at its core, it is a non-specific approach. And so unpublished data from PSORC, which has been submitted to the SIOP meeting, suggests that the sensitivity and specificity is around 80%. So look forward to that data in October. So if the first generation of fluorescence-guided surgery relied on the inherent properties of ICG, including hepatic clearance and the EPR effect, second-generation fluorescence will rely on novel fluorescent agents that are engineered to target specific molecular markers. So before we even dive into that, there are also things that you can do in a sort of next-generation model to look at new things. So ICG is hepatically cleared, and therefore you can use it for fluorescence cholangiography. Many of you have probably used this during laparoscopic or robotic cholecystectomies to visualize the bile ducts. The same concept can be used to visualize the ureter. So instead of having an agent that's hepatically cleared, there are multiple companies that have created agents that are renally cleared, so that instead of lighting up the bile, it lights up the urine, and that can be used to visualize and protect the ureter during surgery, including cancer surgery, obviously. We are currently enrolling patients on one of the phase 3 studies looking at this approach. So besides just altering the clearance properties of a molecular imaging agent, the ability to conjugate a fluorescent tag onto any monoclonal antibody offers the promise of tumor-specific fluorescent-guided surgery. And so we'll use the folate receptor as an example. Many tumors overexpress the folate receptor alpha. So utilization of a folate ligand that is conjugated to a fluorescence tag can selectively target and illuminate these cells. Similar examples are in the works for neuroblastoma using anti-GD2, and Marcus is going to talk all about this, glioblastoma using EGFR antibodies, and for prostate cancer using PSMA. So let's talk a little bit more about folate receptor expression. So the folate receptor is a cell surface protein which plays an important role in various cell functions, including DNA synthesis, repair, and methylation. It comes in a couple of different forms. Folate receptor alpha is overexpressed in many tumor cells, including osteosarcoma. And in this upper right picture, you can see an example actually from Wilms tumor, where folate receptor alpha is overexpressed on the tumor cells. Folate receptor beta is overexpressed on some tumors as well, but also importantly, it's expressed in tumor-associated macrophages in the tumor microenvironment. And so the bottom picture shows an example from a patient with rhabdomyosarcoma where folate receptor beta is expressed in the microenvironment. So pifolucyanine is the first FDA-approved folate receptor conjugated antibody. It's an folate analog ligand that's conjugated with an indole cyanine green-like dye, and it's FDA-approved in adults with ovarian and lung cancer. The FDA indication for lung cancer came from the ELUCIDATE trial, which was a phase 3 trial of 112 adult patients with lung cancer. And in this study, investigators found that in more than half of cases, use of fluorescence-guided surgery with this agent provided a beneficial impact on the surgery. And that came in a couple of different forms. It involved helping to avoid close margins. It involved allowing the surgeons to identify a primary tumor that was difficult to find otherwise. And it involved finding occult synchronous lesions that would have otherwise been missed. So we then set about looking at how we could introduce novel technology like this into pediatric practice. And we took a stepwise approach. And so the first thing we did, and we're going to talk about each of these steps, the first thing that we did was we used the drug in this approach on label in young adults using FDA-approved indications. We then did an in vitro analysis looking at a panel of common pediatric tumors that metastasize to the lung to see what the expression of folate receptor alpha and beta is. And then we took that data and did an investigator-initiated application to the FDA for an investigational new drug application to study this in a safety and feasibility trial. So let's start with young adults. So we used this approach in a couple of young adults with osteosarcoma. We gave this to an 18-year-old and a 24-year-old with osteosarcoma. And you can see a couple of examples of that, a big primary parenchymal nodule on the top, and then extensive pleural disease where the ICG helped us to really define the boundaries of the pleurectomy. Combined with data from our colleagues at Mayo, this bigger panel is being presented at the IPEG meeting this summer. So there are some dosing and detection nuances with poffolicyanine, just like with any other fluorescence-guided surgery. So the emitted wavelength of light is different than that for ICG. So you can't use all the same detection systems for identifying this and some of the other novel agents. And so currently, the only commercially available system that will detect this is the newest Stryker 1788 system, although there are other systems in the works that will detect this. The medicine needs to be given as a slow infusion over 60 to 90 minutes. Depending on the indication, it can be given anywhere from 1 to 24 hours prior to surgery. It's really important to discontinue all folate-containing supplements 48 hours prior to the medicine infusion. Otherwise, you get competition with those folate receptors that would impede the efficacy. And then the medication does risk causing nausea and vomiting, and so pre-medication with Zofran and Benadryl is advisable. So then let's talk about some of the in vitro data. So we used immunohistochemistry to assess folate receptor alpha and beta expression in 18 specimens from 13 patients. This included specimens from both primary and metastatic sites, and it included both pre and post chemotherapy. And again, this data has been submitted as an abstract for the SIOP meeting in October, but the high-level view is that this panel suggests wide applicability of tumor imaging with poffolicyanine or other folate analogs. So taking this data, we then moved on to really designing a phase 1 study. And so often in pediatrics, the problem is that getting regulatory approval for novel agents in children is hard. And so the tendency is often to just begin using the drug off-label in children and then kind of go from there. And that's really not what we wanted to do. So we really set out to do this, quote, by the book. And so using that data, we submitted an investigational new drug application to the FDA to study the safety and feasibility of poffolicyanine in children. That study, that was approved, and the study is now on clinicaltrials.gov, and we are currently enrolling and have enrolled 2 subjects to date. We're including patients aged 6 to 17 who are having planned pulmonary metastasectomy for common indications such as osteo, non-rhabdoid soft tissue sarcoma, and others. We are requiring at least 1 nodule to be greater than 4 millimeters or greater. Here's an example from one of those first trial subjects. This is a teenager with alveolar soft part sarcoma who had multiple pulmonary mets. And this is, what it can look like when it's, really fluorescence-guided surgery at its best. And so most of these pictures are in the overlay mode where you're seeing the fluorescent signal projected on top of standard white light imaging. And this helped us to identify and remove these nodules. When trying to find additional nodules, I really prefer the contrast mode, which is the bottom right image, where you really are only seeing the fluorescent signal and can hone in on any areas of suspicion. So what are the next steps? I really believe that it's important, like I said, to kind of go through the steps appropriately. And so I think any recommendation for pediatric utilization should await FDA approval. And I think it'll be important to really understand the comparative benefits and risks compared to other technology. And so, understanding the pros and cons versus things like ICG, which again is also off-label at this point for pulmonary metastasectomy. It'll be important to understand the limitations. So how do the different histologies impact this? What does the extent of pre-treatment do on your ability to visualize nodules with fluorescence? And what are the other unknowns that we don't even know about yet that might impact the success or failure of these approaches? And ultimately, the question is, can we eliminate other adjuncts for identifying these nodules? Can we get to the point where we have an approach with fluorescence surgery that is sensitive and specific enough that we don't need to do coils or wires or other things to reliably find the nodules? So this is not where the pipeline ends. There are multiple other next-generation fluorescent agents that are in the works. And basically any cell surface marker that is unique to a tumor can be used as an opportunity for a novel fluorophore. And so these multiple additional targeted agents are under investigation, and some are already in the clinical pipeline. They don't all rely on cell surface markers. There's a system called Onboard, which is a micelle which releases fluorescent payloads selectively in the highly acidic tumor microenvironment, which is under investigation. But the majority of things in the pipeline rely on these cell surface markers and antibody sort of derived fluorophores, including antibodies against PSMA, which actually amazingly might be useful not just for prostate cancer, but for a variety of other tumors, as well as anti-GD2, which Marcus is about to tell you all about, but actually might be interesting not just for neuroblastoma, but also for other tumors that express GD2, such as osteosarcoma. But the fundamental limitation for all of these is the depth of penetration for the near-infrared light. And so it is certainly less than 1 centimeter. It's probably optimal when it's even a narrower band of normal tissue that it needs to go through. And so this is where, this will segue nicely into Marcus's talk about what can we do besides just relying on fluorescence to help us be able to identify reliably nodules regardless of their location in the lung and elsewhere. So with that, I would like to thank my great research team and the PediaSurge group. And we're going to take questions at the end of the entire panel.
Okay, thank you, Dr. Lautz. So it's my great pleasure to introduce my friend and mentor, Dr. Marcus Malik. Clinically, he serves as the Director of Surgical Oncology at Children's Hospital of Pittsburgh. And in his lab, the Malik Lab, they've made significant strides. He has an R01 grant, and we look forward to his talk, specifically titled Intraoperative Molecular Imaging Targeting GD2.
All right. So good morning, everybody. It's really an honor and a pleasure to be here to present this work in front of this audience, international audience, both colleagues from IPSO as well as the group here from APSA. So this is really exciting, and also honored to follow Tim with his excellent work. So I want to take a step back for a second and talk about why do we need intraoperative molecular imaging, right? So we can get really excited and look at all these great pictures, but ultimately, do we really need this? The answer is going to be yes, but we're going to walk you through that here for a second. But so inspection and palpation, right? That's what we've been using for the most part to date, other than some early attempts at radio-guided surgery, the current status of fluorescent-guided surgery, which, as Tim has shown, is really growing and improving. But for the most part, inspection, palpation, that's what we do. We go in there, we look for it. The tumor is next to the spleen on the CAT scan, so we go and look next to the spleen. Right, but we probably can do better than that now, right? More importantly, there is a high rate of inadequate tumor resections, unfortunately. Despite our best efforts, and we know that we all always put forth our best efforts to resect these tumors. But in sarcoma, the rate of inadequate resection, meaning positive margin, can be 40% or higher, depending on the study. Nephron-sparing surgery for Wilms tumor. Some studies are showing inadequate surgery rates of up to 33% with high positive margins, some gross positive margins. Neuroblastoma, we've talked about this a lot this morning. Inadequate surgery rate in COG and PSYOP studies up to 30 to 50%. So clearly, we're using fairly primitive techniques, and we need to do a little bit better. Also, complications, right? So that matters. Neuroblastoma, about up to 50% of patients with high-risk neuroblastoma will suffer complications, about 10% of which are severe complications. So that's why we need to do better. And I'm going to try to convince you all that intraoperative molecular imaging with things like ICG and second-generation agents are the way we can do better. The other question is, what's a good target? So if you have a tumor that's very easy to find that we're doing really well with, that's not the tumor that you want to target. So as our group sought to think about what do we want to study, we said, okay, let's look at something that's prevalent. Let's look at something where we can do better in terms of a resection. So we focused in on neuroblastoma. Now, another way to do it is to use tumor-agnostic agents like ICG to some extent, like Cytolux to some extent, as folate receptor alpha and beta are very common across multiple tumors. And this newer agent that is released in the tumor microenvironment due to low pH that also is fairly tumor agnostic. So that's one other way that you can approach this. We've decided to specifically target neuroblastoma, the reason of which are labeled here. We talked about this a lot this morning. I don't need to go through it again, but high rate of inadequate surgery, high rate of complications, so we need to do better. And we also know that we already have an antibody that targets neuroblastoma via the GD2 antigen. So here's a frightening image I think we've all been faced with neuroblastoma. And you might say, well, do you really need a special agent to find that tumor? And the answer is no. However, it might be helpful to know when you're working on the supraceliac aorta and you're in that sort of thick scar tissue and you're wondering, do I need to keep going? Do I need to continue to dissect here, or are we done? Do we feel like we've done a complete enough resection? It could be helpful in that case. Here's an area where I think it is potentially could be a little bit more useful for neuroblastoma. When you have occult deposits of disease or remote deposits of disease like shown here, which is not infrequent. So you can imagine you're working in the chest and you've got to find the tumors down in the retroperitoneum and in the iliac area. Utilizing fluorescence and or radio guidance could help you to find those remote deposits of disease. And again, could confirm complete resection by lack of fluorescent or radio signal. So now I want to pause, again, in the spirit of APSA IPSO here. Mark Winnen from the Netherlands was kind enough to share some slides with me. Dominique, his PhD student, is also going to present next. These are their slides, and they have been working also on anti-GD2 for neuroblastoma using the same near-infrared dye that I'm going to talk about in a moment, and have had some really excellent success. Here's from one of their publications in scientific reports showing really very tumor-specific uptake, and they are in the midst of starting an early phase clinical trial to study this in children across the Atlantic. So to talk a little bit about fluorescent-guided and radio-guided surgery. So it's important to understand is we actually decided we wanted to utilize both tracers for our agent. So it's important to understand the benefits of each, right? So fluorescence-guided surgery, near-infrared fluorescence, that's what we're talking about with ICG, et cetera. You really get very little signal from background tissues, which is great. So your tumor to background ratio, that's the key to any sort of guided surgery, is very high with a near-infrared tracer because you don't get much background. Also, it provides, as Tim showed beautifully in those slides, really nice sharp edges in terms of the optical. So if you're operating, you can very much see the border between normal and abnormal. So that's beautiful. The thing about it that's not great, as Tim pointed out, is the penetration. So less than a centimeter, as Tim said, we have some data showing maybe as little as 4 to 5 millimeters where you get reliable penetration through tissue. So that's always kind of been the downside of fluorescent-guided surgery. Radio-guided surgery, while it does not provide sharp optical borders like fluorescent-guided surgery does, it does, however, have excellent depth of penetration and is extremely sensitive. So it provides the benefit of helping you to find occult lesions and also to confirm complete removal of tumor. So we decided to combine these two agents onto essentially anti-GD2 or dinutuximab for our study. So we'll get into that. I can skip that there. So dinutuximab, obviously a good target. IR dye 800 is the near-infrared that Dr. Winnen and our group are using. DTPA is the chelator to which we radio label with indium-111. So we'll get through this. I'm going to try to catch up on some time here. So here's our model neuroblastoma. I talked a lot about this morning as well. We essentially expose the adrenal gland, inject directly into the adrenal gland, and we are using the SKNBE2 cell line, which has been well shown by multiple groups to grow very well in this orthotopic model. Here it is on MRI at 4 weeks. You can also do this via ultrasound. So you see the tumors grow very nice within 3 to 4 weeks. Then we are injecting our dual-labeled radiotracer via the tail vein. And then we, right away, having a surgeon involved in this lab, I didn't want to just create a tracer that you're going to detect with benchtop tools. We want to create a tracer that we can use in the OR. So from day one, we've been trying to detect our tracer using the neoprobe and using the SPY-5. So here's our near-infrared fluorescence imaging. This is clearly the tumor, and you see really beautifully, it highlights very nicely. Here's some ex vivo images of the same. Now, of course, we did do our benchtop tool analysis as well. This is a biodistribution of fluorescent intensity, and you can clearly see that both at day 4 and day 6, there is a very significant tumor versus background ratio of our tracer. Now, when we use an IgG isotype control, so a non-targeted IgG, you see that that goes away. And so this controls for what Tim had mentioned earlier, the enhanced permeability and retention effect. So how do we know it's not just getting in there because of leaky vessels in the tumor? So this proved to us that that's not the case. So we know it's sensitive. We also know by these data that it's very specific. Similarly, using gamma detection, that was using fluorescent detection, here's using gamma detection. We had excellent detection of our radiotracer in a similar way, and very little detection of our isotype control within the tumor. And so getting back to the tools we use in the OR, so this is the neoprobe we all know and love, or maybe we don't, but we all know. And so here is, you clearly see that in the left flank, which is the region of the tumor, you see really good signal. And then here in this processed tissue cube that some of you may recognize as SPAM, we did bury a tumor deep within it. These were in the early days prior to funding, so we've done a little better than that. But this was pretty exciting. So we could detect the tumor at about 4 to 5 centimeters deep within our processed tissue cube. And next I'm going to show you a little better example of that. So here I actually did this surgery, and I thought I did a pretty good job. So I did a white light operation. We gave this animal the tracer. I did not use the IMI to resect the tumor. I did my best, and I thought, here we are post-surgery. I felt pretty good about myself. And then I threw the near-infrared on there, and sure enough, there was some residual tissue, which we have then resected via the SPY-5, and found under histology it was in fact neuroblastoma. So this is just an in vivo demonstration of how we are leaving tumor behind, and these tools can help us to improve. The next thing to really, interestingly, we talk a lot about, okay, near-infrared fluorescence only gives you this depth of detection, gamma gives you this depth of detection, but no one has ever actually formally studied that, right? We just we go based on, we do a case and say, okay, that tumor was 1 centimeter deep and I saw it or I didn't see it. That's really what all those data are based on. There's essentially nothing out there where they've actually tested it. So we decided that we were going to go beyond SPAM and use phantoms to actually study the limitations of our tracer to be detected by our operative tools, the neoprobe and the SPY-5. And this is just sort of a schema showing that. This is a piece of tissue. And in this slide, you can see we've actually placed our tumors here with nothing over top. And here, these are porcine tissues. So in this case, adipose. Here we've got muscle. This is abdominal wall, lung, liver. We've also done a variety of other organs as well. And we're looking at the detection. Essentially, we're cutting to a specific thickness and looking at the minimal point at which, the maximal point at which we can detect tracer. And so for near-infrared, unfortunately, it was only about 4 millimeters depending on the tissue type. Now, we did similar with detection of gamma decay, and you can see pretty clearly we were able to detect gamma at a depth of about 5 centimeters. This is with tissue. We also used gelatin infused with hemoglobin and other factors to simulate physiologic conditions. And we also saw that our fluorescent detection was limited to a few millimeters, while our gamma detection was able to be realized at up to 4 or 5 centimeters. So this is a fairly cool experiment that we did where we actually had my resident and postdoc, Lauren, who's going to be presenting in the afternoon. She actually buried these tumors in a porcine abdominal wall here, then flipped it, and we had my lab tech try to find it. So trying to find without any IMI was very difficult, even when provided with a photo of where they were buried. And there was a significant amount of tissue damage and time in order to identify. However, using the NeoProbe, she was very clearly able to identify where the tumors were and then dissect down to the tumors, which could not be seen by fluorescence until we were right on top of them. So this is sort of just like a simulation walking through of a surgical use. And here you can see that the fairly accurate plane of dissection that was utilized for that resection. So in conclusions, dinutuximab, IR800, indium-111 accumulates in our neuroblastoma xenografts. The accumulated agent allows for detection of neuroblastoma using widely available surgical tools, the NeoProbe, the SPI-5, we all know. And then gamma ray detection enables identification of occult tumors through as much as 5 centimeters of tissue, while fluorescence was limited to just 4 or 5 millimeters. However, the fluorescence provide beautiful, sharp contrast between surrounding tissues. Our future directions, optimizing the work. We currently have an international patent filed. We have a provisional patent and FDA orphan drug designation, and we are planning and working on early phase clinical trial. It's not easy to get through the FDA, so kudos to Tim for all his work to be able to do that, and I will be asking you for advice on that. And other GD2 expressing cancer. So I'm gonna conclude here. Osteosarcoma, for obvious reasons, is gonna be super exciting to use this for as well. It's about 95% prevalence of GD2 in osteosarcoma also. So that's about it. This is my group, and we'll take questions at the end. Thank you.
Thank you, Marcus. So we'll get on with Dr. Dominic Simmons, who's a technical physician and PhD student in the Vision and Pediatric Oncology Group at Prinses Máxima Center in the Netherlands. And she's going to talk to us about ADC and 123 IMBG imaging for neuroblastoma surgery. Please, Dominic.
Thank you.
Welcome.
Hello, thank you everyone for inviting me to speak here. I'm Dominic Simmons, and I'm a technical physician and a PhD candidate at the Prinses Máxima Center in the Netherlands. And I will talk about ADC and MIBG imaging in neuroblastoma surgery. I have nothing to disclose. So, as we all know, neuroblastoma is very surgically challenging, and this is mainly due to the location of the tumor and the adhesion and encasement to the vital structures. So in this MRI scan, we can, for instance, see that it is encasing the aorta. And we also know that the tumor is very heterogeneous, so it has a lot of different subtypes. And on top of that, there are also a lot of therapy-induced changes causing fibrosis or calcifications within the tumor. And therefore, there's a very high risk of complications during the surgery of about 40%. So the main goal for surgeons is to resect more than 95% of the tumor while sparing those anatomical entities that it is attached to. So what we always do at the Prinses Máxima Center is that we make a preoperative 3D model of the anatomy of the patient. And we do this based on the MRI scan of the patient. And here we can see that we make a model based on the MRI. And we also include IDRFs that are visible in the imaging. So we use this to prepare the surgeons, to prepare for the difficult surgery, but also for patient information and to make the discussion more easy. And here we can see that a complete resection is often very difficult due to the location. So here, for instance, the aorta and the vena cava are encased by the neuroblastoma. And this may lead to the surgical dilemma of whether to resect more tumor tissue with possible complications or whether to leave some residual tumor tissue behind, not knowing whether it's benign or malignant. And through this, we came up with a research question of whether we can integrate the heterogeneity that we see on the preoperative imaging into our current 3D models to distinguish non-vital from vital tumor tissue. So a little bit of background. At diagnosis, we often see very big neuroblastomas, but they change during the time when we give them chemotherapy. And they change in size. So in the upper row, we see the diagnostic images, but also in biological behavior. So at diagnosis, we see a lot of uptake and a lot of diffusion restriction. But after chemotherapy, we see only a little hotspot in the neuroblastoma from the MIBG, and there's no diffusion restriction. So we want to use this metabolic information that we see on the ADC scans and the MIBG imaging as we think these can potentially be biomarkers for tumor vitality. So first of all, ADC imaging. ADC imaging measures the diffusion of tissue, in which if a tissue can move freely, there's no diffusion restriction, and this will appear as a white signal. However, when there's diffusion restriction, the water molecules cannot move freely, and this will appear as a black signal. And we know that tumors often have a very high cellular density, causing a low signal. Then we have the MIBG, and we know that the MIBG binds to neuroblastoma cells through the NET receptor. And for the MIBG, we often look at the uptake in the tumor compared to the liver. And when there's more uptake than in the liver, we consider it pathological. But how do we integrate this information in our 3D models? As we just saw, we make 3D models based on our MRI. However, the ADC and the MIBGs can have a different 3D position. So here in blue, we can see the ADC image or the MIBG image in a different position, so we have to perform image registration. And we can either do this with the free software tool from Elastics or with certified software, for instance, from Mimics. And now we can see that the kidneys overlap, and then we can use the information of all scans. So after we have a good alignment of the scans, we can use the tumor segmentation that we made on the MRI to obtain the ADC and MIBG values within the tumor volume. So here we superimpose the tumor segmentation on top of the MIBG, and then we can make risk group delineations. So we consider it high risk when there's MIBG uptake or when there's diffusion restriction, and we consider it low risk as there's no MIBG uptake or no diffusion restriction. So in this case, we saw that the more lateral side of the tumor had MIBG uptake, so this will be delineated in red, and the area without MIBG uptake will be in green. And when we do that for every 2D slice, we get a 3D visualization. So here we have a model of the 3D model of the tumor, but we incorporated the MIBG imaging within the tumor volume. And here we see why this might be of value, as we can potentially guide surgeons to the high-risk areas. So here the more lateral side of the tumor was considered to be high risk, whether the more medial side of the tumor was low risk. And this way we want to guide surgeons to the area that really has to be taken out, but also to the areas that might be benign or already dead, to lower the surgical complications for neuroblastoma surgery. So to test these models and to validate them, we included 19 patients, which all had preoperative imaging consisting out of an MRI with an ADC scan and an MIBG scan. And they all had signed informed consent to use their imaging and pathology data. So first I want to show you some results of the models that we made. And we had two main findings. The first one being that the ADC and the MIBG models showed similar results. So here they both show the same areas of high risk at the more lateral side of the tumor, and the same area of low risk on the more lateral medial side of the tumor. However, what we also saw that there were differences between the ADC and the MIBG models. So here we have similar areas with the square in yellow. We can see that both the models show the more cranial part of the tumor to be high risk, whereas there are also different areas in the circle where the ADC image shows that there's a high-risk component, and the MIBG scan shows that there is a low-risk component. And this really made us wonder what the pathology is of these areas. So to correlate the imaging to pathology, we have two main methodologies. And the first one is based on an en bloc resection. So this is mainly for the smaller tumors or the tumors that do not have any IDRFs. And for these tumors, we use the tumor-specific cutting guide. And we can see that here in yellow. It's sort of like a model that we use, and we place it around the tumor in a virtual 3D planning. And then we have to align it with the MRI scan. So we place it in the same orientation as the MRI slices, and when we go through the MRI, every MRI slices falls between the partition of the cutting guide. And then we can extract the 3D model of the tumor from the cutting guide, and we sort of get a mold for the tumor. So we leave a little bed behind to place the tumor in. And then we 3D print that cutting guide to use intraoperatively, in which the surgeon can actually place the tumor after resection. Then at the pathology department, we can use this cutting guide to slice the tumor in slices with the same thickness as our MIBG and ADC imaging. And this way, we obtain a direct pathology imaging correlation. So here we can see that the tumor has been sliced with the cutting guide. However, as we know, neuroblastoma surgery is really hard, so often this is not the case, and we have a resection in multiple segments. And then we use a patient-specific anatomical map. So we just make a 2D print of the anatomy of the patient, but we do this in real size. So the kidney are the real size of the patient. And then we place the segments on the map when a segment has been removed. And this is done intraoperatively by the surgeon. So when a surgeon takes out one segment, he or she will place it on the map so we know exactly what location the segment was in. And then again, we have a standard cutting guide that we use. So we place at the pathology department, we place a segment on the cutting guide, and then the pathologist can use the cutting guide again to slice the tumor. Then to correlate and validate the models with pathology, we analyzed 5 slices of interest per patient, and these were slices that had either diffusion restriction or MIBG uptake, or slices that were ADC and MIBG negative. And for these areas, we denoted the histopathology. And we had 4 main categories that we used. The first one being neuroblastoma, then ganglioneuroma, and we had mixed pathology. Those were the areas where only a focal spot of neuroblastoma tissue was visible. And we have the other category, in which necrosis, fibrosis, calcification, but also benign tumor tissue was classified. And then for these patients, we mainly looked at these 5 slices, which are pointed to with the arrows. Then I want to share with you some preliminary results that we have. This is still work that we're working on, but for this model, for this patient, we looked at the first region of interest, and it was a region which had both on ADC and MIBG imaging and high-risk area. And when we looked at the pathology results, we saw that there was 70% vital tumor tissue within that segment. So here we can see that indeed the high-risk area contained very vital neuroblastoma tissue. Then we looked at the second region of interest, which had a high-risk area on ADC imaging, but a low-risk area on MIBG imaging. And here we saw that the pathology results still showed 50% of vital neuroblastoma tissue. So here we saw that the MIBG showed a negative area, but there was still a lot of vital tumor tissue inside there. And here again, we see an area with very high-risk tissue on both the ADC and MIBG model, and the pathology also contained vital neuroblastoma tissue. And when we looked at those first patients, we mainly saw that when ADC and MIBG risk models give high-risk areas, they often contain vital neuroblastoma tissue. However, if they did not show any high-risk areas, so it was low risk, we also found that there was often still vital neuroblastoma cells in there, for about 40% for both the models. And this brings me to my take-home messages. The ADC and MIBG negativity does not mean that there's no vital tumor tissue inside there. So we need to explore the imaging in larger studies and look at the differences between the pathology results for those areas. And we need to explore the value, especially if we want to make clinical and surgical decision-making on this. And maybe we need to look for more accurate imaging modalities, such as the anti-GD2 iodide 800 double CUW, which Marcus just told on, and which we will start working on in coming year in a clinical study, first-in-human study. And with this, I would like to thank all of my colleagues, and thank you for your attention.
Great, thank you, Dr. Simons. Beautiful pictures. So now we'll move to the question portion of our session. We have about 15 minutes, We'll take questions from the audience, and then if there are any questions virtually as well.
Peter?
Hi, a wonderful talk from all three, but particularly for the last one. One of the challenges of these reconstructions is how accurate those models are. And I know originally the models had to be kind of hand done. And can you tell me where you are on the accuracy of those models and the computer segmentation?
Yeah, does it work? When we did the image registration, we first performed a validation method to look at how accurate the models were. And we had an accuracy of about 5 millimeters. And what is really important when placing the segments in the cutting guide or on the map, there's always some movement and some orientation differences. So what we do at the pathology, we slice multiple segments. And when we are interested in an area, we also take the upper and the lower part in consideration. So we do not base it on one single slice. So in the whole segment, we look at the pathology results, whether there was neuroblastoma tissue or not. So we're not there yet to look at a specific slice with only a millimeter's accuracy.
Echo Dr. Ehrlich's comments as really great talks. Question is for Tim. So I always ask the Stryker people this. When you think about the fluorescence, is there ability to figure out the derivative or like that area under the curve to tell or correlate the amount of necrosis of the specimen or if it's a true living specimen?
Thanks, Joe. I just want to make sure I understand the question. So you're saying, how can you tell from the imaging what the likelihood of it being necrotic is
Right.
essentially? I mean, there's clearly a correlation. I think we all see that. And it's not just necrosis. I think it's also, when we think about osteo, if it's a well-treated nodule that mostly you just have kind of mature, osteoid deposition at that point, those, I think, are less likely to fluoresce. So I think that correlation, and I think, that's some of the data that hopefully the PSORC data is going to elucidate, is what is that correlation between tumor necrosis, tumor maturation, and fluorescence findings. But even when it's a relatively pre-treated nodule, you can often, still visualize the nodules.
Yeah, sounds good. Thanks.
Thanks.
Hi, David Rothstein from Seattle Children's. You might argue that we should all be out of a job someday and leave surgical care as a medical targeted care. Could you guys speculate in these three talks about how you might blend the imaging, the linked imaging to linked targeted therapy that's kind of blending us in medical therapy? Thanks.
It's a good question. I mean, while Marcus gets his mic, that's this whole field that's, has a catchy name called theranostics, right? Which is repurposing or using agents that are really designed for therapeutic purposes and recognizing that they can also have a diagnostic purpose and vice versa. And I think clearly the answer is both. We need to learn from, what agents are being used for therapeutic purposes, and I think if, molecular imaging data reveals promising aspects, then we should be looking to see if there's targeted, treatment agents also. But.
Yeah, no, I agree with Tim, and I think it's a great point. And precision medicine. Clearly, if we can do it, why not, right? Why not target these tumors? The thing that where I think we have a little bit of an advantage over our medical counterparts is if you're using it for imaging purposes, you probably don't need as much to get into the tumors, right? You just need some of the cells, some percentage of the cells to express whatever you're targeting in order to see it. Whereas if you're actually trying to treat the cells, if the expression of whatever the antigen or target is low, your success rate is going to suffer. So in some ways, we have a little bit of an easier lift in that we just need to get some of it into the tumor so that we can see it.
Hi, thank you so much for such a fascinating talk and for all of your work. I'm Barry Rich from Cohen Children's in New York. I guess to take it a little bit further for what David Rothstein said, what about if they've gotten treatment? So for example, for you, Marcus, if they've gotten dinutuximab in their treatment for neuroblastoma, how does that affect the image guidance after? And would that affect anything in terms of how accurate it would be or inaccurate and how it would be after treatment? Thank you.
Yeah, thank you. That's a fantastic question. It's one that does come up fairly often, and I think Mark and Dominique have actually already studied that in that paper that I referenced in the talk. So I don't know if you want to answer it, Dominique, because you guys actually did the studies.
What we found on when we did an article on that there was still, it was still visual in mice models. However, for the first in human study, we only include patients that did not have dinutuximab already. And maybe after we establish the safe dose, we can actually try to do that as well for the patients with the immunotherapy. But for now on, we'll exclude those patients. But in our center, we mostly do first, of course, the chemotherapy, then the surgery. So we still are able to include a lot of patients, just not yet the dinutuximab patients.
And just to add to that also, I think the timing is important too, right? So most patients are getting dinutuximab after surgery, but as we know on some of the more recent trials, there are arms in which they get dinutuximab up front. So it clearly matters. Also, it's important to note that we're generally talking about a single small dose of dinutuximab as opposed to the 4 or 5 day infusions that patients are getting when they're on maintenance therapy. So I think if you get, and this is something that our group is also going to study in the future, but if you get a small dose of it up front for their imaging purposes or intraoperative imaging purposes, the chance it's going to affect your large maintenance doses later is pretty small. But I think Mark's group also studied pretty large doses up front of dinutuximab, and then we're still able to image it. And so I think either way, it should work out okay. But clearly, since we know dinutuximab is one of the things that makes a difference in survival, we have to be very careful with that going forward.
Thanks very much to all the speakers for really a fantastic session. My question is for Dominique. So if I understand your conclusions, you were maybe a little disappointed with the correlation between the imaging findings and the histopathology. Do you plan to look for correlations with the molecular characteristics of what also is heterogeneous throughout the tumor? It might help you understand, the biology a little bit, and it might also be useful when you follow them for recurrence to see if the recurrence is similar to what you removed or maybe similar to what you left behind, and really help you get at this question of what is really the high-risk area of the tumor.
Yeah, thank you. I think that's a really interesting point that you make. We are actually looking at what we can explore with this data because we now have really interesting data. And we also want, for instance, to look at the biopsy to see how does it vary between the resection that we did and the biopsy that we had. And we also want to do some molecular testing on this. So how is the GD2, for instance? How is the net receptor as those areas that we've resected? And we're also very interested in looking at the pathology of the neuroblastoma tissue, how it varies between the areas that did show MIBG uptake and the areas that did not show uptake, because maybe there is some biological behavior going on there, maybe there's differentiation. So we really want to dive into that to look at the differences and also the inter-patient variability between those patients, because we saw for some patients that it worked better than for other patients, but we're still exploring that.
I just want to check with Laura and Dana. Any virtual questions? No? Okay. So I'll ask a question. So, Marcus and Tim, you guys alluded to this, but working with industry is going to be important to get these technologies into their surgical equipment. So at what point in your process do you guys start doing that so that it's the ease of workflow, it makes it much simpler for the surgeon to use?
So it's a great question. I mean, our approach was to work with what we have, because I really don't, at least, you know, a couple years back when we started this, I had no idea how to do that. I have a little bit better idea now, but so we just designed it for the current systems, and that's where the near-infrared dye comes in, and that's where the indium-111 that we chose comes in. Indium-111 is not a PET tracer. It's not the best imaging agent for like, you know, through axial imaging. It's not great for that. PET, something like gadolinium or copper-64 would be much better, but indium-111 is better detected by the neoprobe. So we actually kind of worked to fit it into what's out there already. But I think if you have good data, you can take it to industry, and if you can get industry to be excited about it, then they can partner with you. We have some stuff going on with Designs for Visions right now, and I'm not sure, I don't think I can actually talk very much about it, but we actually have some stuff going on with them because they were quite interested in it, and so we're working on some stuff in terms of creating near-infrared visualization. So Tim probably has a better answer because he's had more further along.
Well, I think it sort of depends on what you're dealing with, right? So in Marcus's case, right, he's taking a product from scratch and trying to bring it forward through preclinical into, you know, soliciting interest in clinical applications. Whereas in my case, it was more taking things that have been created for adult purposes and trying to get industry excited about the very small market, which is pediatrics, right? And so we've been fortunate to have great industry partners, but I think that is the challenge for us in this room, which is to say, we have this group of patients, there's 500 in the US a year of this disease, whereas there's 60,000 lung adenoma and squamous cell carcinoma. And so how you know, can we work well with industry to be able to study these exciting innovations in a small market?
I'm going to throw in just one other point. I mentioned in one of my slides, we also filed with the FDA for orphan drug status. That is another important thing that I had not been aware of prior to that. So any of our pediatric tumors would qualify as orphan drugs. I think it has to be less than 200,000 cases per year, something like that. So we have no trouble with that. But that does allow you some benefits with the FDA in terms of getting approvals. It also, there are many benefits on the back end if you actually are able to get an investigational new drug application in terms of bringing that to market. So that is put in place by the government to encourage people like us to do research on rare tumors and pediatric tumors. And so those are things that are worth exploring as well.
Steve Allman, Driscoll Children's Hospital. Is there anything new that will help us see the parathyroids in thyroid cancer surgery? We've used the neoprobe and we've tried to use ICG, but it hasn't worked very well. Is there anything specific we can use there, help us there?
Do you have I mean, so they autofluoresce, right? I'm not an expert in this, but I know that if you have, one of my partners actually has interest in this technology where you can use spectroscopy that's not looking at just those fixed wavelengths that we're used to detecting with commercially applicable systems, and you can detect autofluorescence. And so the technology is for sure there, but the commercially designed systems, I'm not sure what is out there, to be honest. Maybe Jenny knows.
Well, the system we use is called PTI, which works exactly how you described, but it's more of a confirmation test. You find it with your eyes and then localize it, so it's not sort of a de novo localization.
Yeah.
Thanks, Jenny. So we have 4 seconds to end the session. So I would like to thank the speakers for the excellent presentations and for you for participating with the questions. And I also would like to acknowledge Drs. Boomer and Schwartz for the co-chairing the session. And not to lose any precious time, I would like to invite both Dr. Kimberly Hale, who's an associate professor of surgery at the University of Washington and surgical oncology researcher. She's an attending surgeon at the Seattle Children's Hospital, and Professor Paul Losty, who is the IPSO president, and Professor of Pediatric Surgery at the Hayes Children NIH Foundation Trust at University of Liverpool, to chair the next session. Thank you so much for your attention.